Hello, everyone. My name is Jen Sharon, NHIA's Chief Operating Officer and your moderator for today's very first education session in NHIA's summer series, Proactively Identifying Risk and Medication Errors in Home Infusion, How to Ensure Consistent Learnings When Events Occur. This education session is the first of a weekly programming on Wednesdays at noontime Eastern through July, focused on providing you with free education in CE that you would have enjoyed at our annual conference in April. Make sure to watch for Infusion Express social media as well as eBlast for upcoming sessions and to register. I'll give a little hint too. We have a couple of weeks where we actually have 2 sessions going on at the same time. So we're really excited to bring this education free to members. Just a couple of housekeeping reminders. The presentation is available for download from the handout section of the navigation pane. The webinar will be recorded and a link of the recording will be emailed to you following the conclusion of the webinar and will also be available via NHIA's website within the next 24 hours on the Summer Education Series page. In order to receive CE, please follow the link in the follow-up email and answer a short quiz. Following the presentation, we will have time to answer your questions. Please submit your questions via the question tab in the navigation pane at any time during the presentation. Okay, now on to our main event. Our speakers today are Matt Grissinger, Director of Error Reporting Programs at ISMP, and Laura Haynes, Manager of Quality and Patient Safety at Penn Home Infusion Therapy. For more information about Matt and Laura, their bios can be found in the handout section of the navigation pane. Matt, let's get us started.
All right, thank you, Laura, for the introduction, and I want to welcome everyone to this webinar today. Laura, I'm sorry, that was Jen. Both Laura and I will be presenting this today, doing half of each. This is just our disclosure saying that we have spouses that work for companies, but it does not affect our presentation today. And this is our objectives, which I won't read over, but the overall theme here is talk about the many reasons why there's risk and possibly errors in home infusion pharmacy and home care. So we're going to go over the whole big look at the system-based approach to errors, talk about latent failures and active failures, describe some strategies as we go along, and then go into how to do an event investigation using tools like RCA and the 5 whys that Laura will talk on at the end of at the second half of the presentation. So to get started, to take a broad look for everyone, keeping in mind everyone on the phone here who may be in home infusion pharmacy, home infusion pharmacies varied. They're not all the same in how they're set up and whether they have home care nursing or not. So we see a lot of variety of ways that home infusion therapy is provided. And it's important to think that when errors are occurring, often we're concluding or thinking that at the end of the day, the error happened because Jen wasn't paying attention and she misread the label and gave out the wrong drug as an example, where we focus on the second bullet on the sharp end, which is the pharmacy tech, home care nurse who may be handling a product as an example. But there are a lot of issues in the workflow of home infusion therapy that sets your staff up to fail. And that's what we call the blunt end in this third bullet. And that involves your organization policies, but I will summarize it by saying it's really the summarization of your processes. So, we have a big clinical role in home infusion pharmacy, but what about the processes involved in delivering care? And when I say the processes, refer to the screen here, because medication use in home infusion is not just pharmacy. I think at times in home infusion, we think when errors occur in home infusion pharmacy, it's strictly because we gave out the wrong bag to the wrong patient. And that could not be further from the truth. There are a lot of breakdowns happening that are contributing to other types of clinical issues that we may not be aware of, or luckily just hasn't happened yet. So think about the whole process. Let's go to the top left of the screen here, that whole history taking part in home infusion and that incoming referral. What type of information are we getting up front? How is it documented? And people listening in, what type of errors have happened in the referral process, getting information, which could be the initial intake or the pharmacist getting more information? What type of problems do we see there? And then there's the issue of the ordering, whether the physicians are close by or far away. We're having to call and clarify orders. The whole order process is next, followed by the pharmacy end of this, which is getting the referral, evaluating the order, doing the order entry, making stuff and delivering. But also, what are you buying? What are you stocking? And with drug shortages, must be playing havoc for some of you as well. So that is really interrupting some of this process, including maybe even changing original orders. The process then goes, once the stuff is delivered, the education piece of not just the patient, but of staff. In the administration in the home, which is obviously different than other care settings in healthcare, where we have a really active patient caregiver into this, and sometimes the home care nurse. How are things documented? Does the pharmacy read what a nurse documents down here ever? How are we evaluating the response to the drugs, both on individual patients, or nurses communicating that back to the pharmacist, but also globally as well from a 30,000-foot view over a 3-month period? What type of issues have we had, both preventable adverse drug events or medication errors, or maybe it's unpreventable adverse drug reactions, but what type of things are happening to our patient population? So through the rest of my presentation, please keep in mind that I'm referring to this whole slide. I'm not referring only to a physical drug, but all the processes associated with drugs. So in ISB's perspective, this is how we look at why errors occur. And these are essentially chapters in a book, right? These are essentially 10 chapters of types of contributing factors. And I don't have time to go over all 10 of these today, but the ones in bold: patient information up front, communicating orders, and I'm going to throw in order entry systems here, along with the environment we work in, the storage of drugs, and also staff competency and education, which, in a former life, I was a Joint Commission home care surveyor, and I'm pretty sure one of the two main things we cited often from a Joint Commission perspective was competency issues, because competencies at the time really weren't addressing the concerns you may have in field. So let me go through all this. So let's talk about patient information first. So this is a very clinical looking slide. So as for the pharmacists on the phone and the nurses, think about that information that you need to feel comfortable sending the order to the home. Now, when I say comfortable, I hope that doesn't mean you're forgetting some things, right? So what's the bare minimum clinical information you need? Lab values is obvious for some drugs, but do you get it for all drugs? Height and weight for certain drugs dosed by weight, or BSA. You get the diagnosis for the person you're treating, but what about the diagnosis? What about the other diagnosis that it may impact your decision? Are you looking at the big picture, or only the diagnosis for what I'm giving out, as an example? Allergies. We all ask for allergies, but do we have the reactions that go with that? Having an order for, say a patient comes in, cefazolin 1 gram every 8 hours, and it's a penicillin allergy. Do you fill that or not? And do you call or not? And the answer is, well, you really don't know, because you don't know what the allergic reaction was, as another example. And also all the drug therapy. And I appreciate, having worked home infusion pharmacy, the viewpoint of, well, why do I need to worry about a patient's list of meds? Yeah, I know it's a Joint Commission requirement to do reconciliation, but really, what does that have to do with me, right? And well, maybe it does. What do those medications have any impact on your clinical decision making? And I'll even add one thing on top of this. I think of any practice setting in healthcare that could truly get the most accurate patient medication list of anybody, nursing homes, community pharmacists, hospitals, home infusion therapy, home infusion pharmacies and nurses, to me, would have the best opportunity to have the complete drug list for everybody in healthcare and for the patients. And then there's a patient misidentification piece. And that's not just that I deliver the right bag to the right home, but in the pharmacy, when you're filling orders, how do you know the bag you're making goes with that patient label? And we'll talk about that later as well. So the essence of this part here is the fact that think about those processes associated with all those things in the last slide. So how do you get that information up front? Is it purely from the referral process or not? And I'm going to touch on that later, as we Some of the medication safety issues we see are just as much workflow issues that contribute to the problem. So does a referral come in, but we get half the information, then the pharmacist has to call to get the other half of the information? Or is the expectation the referral person gets everything up front so pharmacists can focus on the order, as an example? Is the information readily available in a useful form, and where's it documented? So pharmacists, are you looking at the home care nurses' logs about all any chance? Are you looking at the progress notes, any drug reactions they had, how they're doing at home with the therapy? Do you look at that? And what is the communication between nursing and pharmacy in this situation? And where is it documented, which I'll touch on later as well? Is the patient information even considered when prescriber dispensing or giving these drugs? And then we'll touch on later the not so good order entry systems in home infusion, where you could enter all that drug information, but at the end of the day, it doesn't impact your order entry. It doesn't stop you from doing anything. So back to the referral process. Think about all that patient information you would need. Now, again, I probably hopefully explained to your mind that what you think you need is not just the order and the allergies. There's more clinically that could have an impact to this patient. So who's getting it? Who's asking for it? And again, can we get it as much up front versus dumping it on that pharmacist down the road who has half the information, but now I can make more phone calls to get the rest of the information? So again, part of it's workflow, but listen, we've all been in a situation on a Friday afternoon at 3 o'clock, and we got 3 new referrals, and we just want to get the drug out the door. Attitude, right? So what's the minimum stuff that you're okay with having before sending that drug out the door? Add on top of that, paper versus electronic health records in home infusion. We're seeing combination of both. And I have to ask you the question, what's the document of truth? If I'm going to look something up, am I going still to the paper chart I have for some of my patients, or am I going to the electronic health record for some of my patients, and where am I going for that? And unfortunately, again, due to what you're given with order entry systems, is definitely not helping you. So think about the communication of orders now. So we've got referral stuff coming in, but now orders are coming in. They can come in from a variety of ways. They still may be handwritten and faxed. We have telephone verifications, et cetera, and how they're being transmitted. But let's talk about the order entry systems in home infusion. And from what we've seen, honestly, between us on this phone call, you're using glorified label printers that are great at billing things. And that's it. It's got zero clinical thought or support for you to tell you, hey, that person's allergic to this drug. Don't give that drug. Hey, that's a 10-fold overdose of vancomycin. You shouldn't dispense that. Stop right now. What do you have to support you clinically when processing orders? There's a screen against other comorbidities, renal function as an example of that. Or is it still a manual labor of looking at paper labs and all that stuff versus the order entry system telling you all this? And lastly, allergies and reaction. Often the problem we fall into is we ask for allergies. They have a penicillin or morphine allergy, but we have no idea what the reaction is. So what's a doctor supposed to think, or a pharmacist, when I see a morphine allergy? What does that mean? That could mean they fell asleep on the morphine. It could mean they had full body rash with morphine. They're 2 different worlds. So that's one issue. And the other issue is, how many of you dispense EpiPens with all these new admissions, just in case? And nothing wrong with that, right? But do you know how many are being used? Out of 100 EpiPens, how many have had to be used for a patient who had a reaction to the drug? Would the pharmacy know that? Nursing would know that, probably, but is pharmacy involved in that? Other order entry system issues, patient weights should always be kilograms, never, ever pounds. Drugs are not dosed in pounds. And you may think, well, Matt, our system converts pounds to kilograms. Well, that's well and good, but we've seen nursing notes where it says the field weight, a number 100, I don't know if that's pounds or kilograms. So I'm entering 100 into what? Is it 100 pounds, 100 kilograms? 2 separate things. And is that consistent throughout all your processes? Because that could impact the dosing of some meds. We've seen free texting of drug names versus a good drug library. I brought this up earlier with pharmacy nursing documentation. Does nursing read pharmacy notes? Does pharmacy read nursing notes? Is there any discussion between pharmacy and nursing, or is it still the siloed approach of, well, that's them, they're going to the home, they'll take care of that, and I'll do my end here in the pharmacy, as an example. And then also quick on supply list of that kind of is partly workflow of who's generating supply list, who's filling them and who's checking them, and who has the authority to correct possibly wrong things on the supply list. So, hey, doing order entry, a pharmacist goes in to enter drug orders. Who's actually checking the order? So you enter the patient, the order, there's allergies, maybe comorbidities, and the supplies. So who's double checking the order entry piece of that? Not just the drug when it's done, but up front. After the label's printed, who's going back at the second check to make sure it was the right patient and that right drug that goes for that person? Now, when you're on call on the weekend, and that's a whole different story, and for some people on the phone, you could be the only pharmacist in town doing this stuff. So that makes it a lot difficult. But keep in mind, when you have one person doing all the work, there's no one to catch mistakes. So who's catching mistakes? So part of preventing errors is catching the error, not just preventing the error. Many of you may be doing chemotherapy like 5-FUs. So what does that look like? If you get an order for 5-FU therapy for 6 cycles, do you assume it's the same order for 6 cycles? Do you call for each cycle to update that? Maybe the patient lost weight. You know if the patient lost weight and that dose should be changed, as an example. So there's some issues we've seen with the fact that we make the assumption, well, it's this 5-FU for 6 weeks. We're just going to fill it for six courses and we're done. There's nothing for me to do because we had the order that's good for a whole year. Well, chemo's not like that, everyone. Chemo can change every time. And how many times have you been caught sending out drugs like a chemo to realize the dose changed after you sent it out? And now you just not only, it's a safety issue, but you just lost all that money on a 5-FU CAD cassette as an example. So yeah, what course is the patient on? Do you know if there's changes in orders? And when are you confirming labs? Is it before the drug goes out the door? And we're going to come back later. Well, in fact, we'll talk about it now under the compounding environments. You know, what takes precedence where you work? Is it safety or when the drug gets delivered? And listen, I get it. I've been there, done that, right? And the driver's waiting at the door. Let's go, Laura. We got to get this drug out the door. Can you hurry up and fill that? I get that, and that has to stop because remember, you're turning home infusion pharmacy to a retail chain drugstore when you take that approach, where people are waiting in line for you to deliver something when safety takes back seats. What's the environment you're compounding in? Do you have enough, besides 797 stuff, how much space do you have? As an example, where do you check the drugs? And I have a picture coming up later as well because, some of us may be filling all of our TPNs on a Wednesday. Well, I have 7 patients on TPN therapy, and that's 7 bags for 7 patients. That's 49 bags. So where am I filling and checking these things? It can be kind of difficult to actively check things. How about preparing? You guys have compounding machines for TPNs. So who's double checking when you set up the TPN compounder in the morning? Who's double checking that? Right? Sometimes I'll have a picture later of even how labels face could cause a problem. And are you using barcode systems to verify stuff as well? And lastly, what's included in the final check? So we're checking products. We all look at the bag. We shake the bags. There's no particulate matter in here. But it's the wrong patient. We put the wrong label in the bag. So remember, when you're checking IVs, it's not just is it the right drug and did it precipitate. What's the process for labeling patient's name on that thing? So here's an example of a classic two small hood because you have a separate hood for chemo. You have one hood for TPNs and one for everything else, right? And here's your TPN hood. And the key thing, top left here, see all these nice barcodes here, which is great. Now, does this barcode line up with that barcode? So who's double checking to make sure these barcodes are lining up with the proper drugs? But secondly now, when I'm actually making and doing the checking, you notice a lot of these vial names aren't facing forward. So how's that helping a person filling over here to double check to make sure the right things are hung? Barcoding is great, but there's other safety issues I don't have time to go into. Predominantly, you have to set up a new drug in a drug dictionary, right? Because as drug shortage, you have to get a different electrolyte. There's a different concentration. And no one double checks that entry. So if it's wrong going in, it would get to this stage, this barcoding is not going to help at all because it was set up wrong in the first place. And again, look how small the filling area here is as well. There's my nice flying arrows. Lastly, checking the final product. And I'll touch on the first bullet on the next slide about the proxy method. But when I'm checking a final product, what am I looking for? Is it one vial, one syringe pulled back after the fact, and that's what I'm using as an example. You can look up this story by Eric Kropp. He was a pharmacist in Ohio who went to jail, was involved in the death of a child in the hospital with chemotherapy, and all the many contributing factors Eric had to go through that day. Part of the problem is when checking the products, there was just a stack. Picture a small metallic cart with compounding sheets, vials, and bags stacked together on a cart. And that's what he had to check. And there's errors that happen in that process, but that comes back to how much space you have to not only make the drug, but check the drug as well. Another one at the bottom, how do you do independent double checks when you're on call for the weekend? ISMP has what we call targeted medication safety best practices for hospitals. So yeah, do they apply to home infusion? Yeah, believe it or not, some of them do. The patient late issue applies to you, but mostly this. So I'm sure most people on the phone, when they check an IV, it means check made it, and then when they're done, they pull back the syringe to an imaginary amount that they claim they put into the bag after they put it into the bag, and you're accepting that as the gospel truth. Yep, well, if they pulled it back to 5 empty mLs, then they must put in the 5 mLs in there. And that's what we call a proxy method, which is very dangerous because you have no idea what's in the bag. None. And listen, this is very tough to change with all compounding pharmacies, hospital or home infusion. But there has to be a method to check what's going into the bag before it goes into the bag, so you know 5 mLs of mag sulfate are going into that bag. It's got to be done actively before the drug gets in the bag and not after the fact when you honestly don't know. And let me throw one quick story in here, because that needs to also include all the vials that you used. Years ago, there was a death that occurred due to a compounding of TPN. Part of it was poor compounding machine where they were adding zinc sulfate. But the compounder said, well, do you want micrograms or milligrams? Which is bizarre. They accidentally picked milligrams instead of micrograms. The tech put in 26 vials of zinc sulfate. And guess what? You know what the final check looked like? 1 vial of zinc sulfate, 1 pullback syringe. It was all it was. Versus having all 26 vials out there. So it's important that you see all the vials that go in, not just the one in that example, or in any example. I want to fly through this to give Laura time here. A couple key things with staff competency and education is, listen, home infusion pharmacy and home care nursing are unique care areas that are not taught in schools. So there are special skills to be a home infusion pharmacist that are different than anything else in healthcare. So when you hire Matt to work for you at home infusion pharmacy, and listen, it's been probably over 20 years since I've been in home infusion pharmacy, what do you expect me to know? So you feel okay with me taking on call and working the weekends by myself. What do I need to know? So what clinical things do I need to know? What process stuff do I need to know? Okay. And also, some places have infusion pharmacies where some pharmacists do order entry only, and some pharmacists are like the checkers at the end, doing supplies, programming the pumps, bagging things up to send out the door. Okay. But when you're on call and you oriented the order entry pharmacist on order entry, what do they know about compounding? You expect them to come in and compound on the weekend. You didn't go over compounding with them. So competency has to be everything that may happen, especially on a weekend scenario as well. So what are you doing also to have ongoing education as well, to learn about potential unsafe practices or stuff from ISMP? Yeah, do we write a lot about home infusion and pharmacy? No, we don't. Do you know why? Because no one tells us anything from home infusion pharmacy. We get no reports from home infusion pharmacy. We have no idea about the risks that you go through. Until we are invited to visit home infusion pharmacies and see workflows, do we really appreciate the risk going on? But that doesn't happen a lot. So how are you contributing to that? But also then looking for other information that may support some potentially dangerous habits going on. And lastly, so how do you identify risk in your organization that Laura's going to touch on later with investigations and so on? So how do you know everything's going fine in your organization? Do you ask employees? Home infusion pharmacies don't report errors, okay? I get it. You don't do it in your pharmacy, in your organization. You don't do it externally. So if you're not doing it, that's fine, but how do you know you have problems where you work? What are people's perceptions about unsafe conditions or risky behaviors or things that almost went wrong? And secondly, what are you measuring to prove there's a problem? Think Joint Commission PI chapter, Performance Improvement chapter. And, right, that includes measuring. So what are you measuring to prove there's a problem? And what are you measuring to prove that things improved? Number of interruptions by phone calls, or a number of times I had to call back to get information that the referral or intake people didn't get. Are all my pumps coming back? Of 100 pumps I'd sent out the past 3 months, how many came back? How many phone calls do we get on the weekend for on call? Or how many interrupt, et cetera, and so on. So one thing pharmacy is bad at overall, which is kind of amazing because we're obsessed with numbers, but we don't measure with numbers to say what we're doing. Lastly, you guys consider doing huddles in the morning. So every morning when you come in for 15 minutes, everyone comes together, a home care nurse representative, the people who are doing the compounding delivery, order entry pharmacists, referral intake people, meet together to say, okay, for today, here's what's going on. These people are going out today. We have holdups. We have something in orders for A and B. We still have to do this for another patient. We're going to have 5 new admissions tomorrow. Oh, and also, who's discharged from service and what do we have to pick up that day? And lastly, drug shortages. We really got to be more proactive informing the staff and probably physician offices about drug shortages versus waiting until today to say, oh, guys, guess what? Today we have no more Vanco, so we're going to have to make calls today, versus we knew about that last week. It was coming. So how are you proactively addressing that as well? So on that note, Laura, I'm going to pass it over to you.
Great. Thanks for that wonderful overview, Matt. For the rest of our time together, I'm gonna briefly review some historical perspective of human potential for error and healthcare quality, introduce 2 tools that you can utilize in event review, and then walk through a few examples. Next slide. Perfect. So it would be remiss if I didn't talk about the Institute of Medicine and then now known as the National Academy of Medicine documents. So in part 1, To Err is Human was published in November of 1999. This was one of the first times that they had staggering statistics about how many people die in hospitals each year due to medical errors, and also equating it to a dollar figure of what types of errors are happening, whether they're diagnostic or treatment, preventable, why we have errors occurring with regards to the reasons. And they hinted at the strategy for improvement in the fact that how do we compare healthcare that is to other high-risk industries, the importance of voluntary reporting within the strategies for improvement, adopting different standards, and then how do we go about identifying errors. So part 1 gave us a taste, if you will. Part 2, published 2 years later in 2001, really with crossing the quality chiasm, really focused on how do we take the knowledge we have within organizations and translate that into practice changes, applying new technologies both safely as also within quality. They hinted at a national statement of purpose, and in the second component, identified 6 different aims for how we want to improve. We want all of our improvements to be safe, effective, to be patient-centered and patient-focused, have a timeliness to them. We don't want to have an error occurring and then there be a lag of any sort. We want it to be efficient and also equal. In addition, part 2 also identified potential rules for redesigning a process where you have data to support that change needs to occur. You need to customize within these rules how patients' needs and values as we have different practice settings, we have different relationships and within each organization and with patients. We need to have the patient realize that they have a source of control within a redesign, knowing that we can share knowledge and information can flow freely, and that we need to be as transparent as is necessary in order to show that we are hearing the events that are occurring or identifying the events that are occurring in order to improve a process. So after part 2, they put together a subset of different categories within quality, and then 5 years later, that's where part 3, if you will, which is preventing medication errors, was published in 2016, or excuse me, 2006, and they looked at how frequent people use medications. First, to give overarching data to support their suggestion that 4 out of 5 Americans use medications within any given week, and that a third of all adults within the world take at least 5 or so medications on a daily basis, which is a staggering statistic, but not probably unfamiliar to folks that on the call. The major goal of this sub-series on preventing medication errors was to help prevent errors through different partnerships. They go back and start to outline different tip sheets that folks can use within different practice settings, whether they be inpatient, home care, ambulatory practices, and all different types of pharmacy components. And so as we have these framework of the human potential for error, I think it's important to discuss that us as humans have a fallibility to them. Next slide.
One second, Laura.
That's okay.
Sorry about that.
That's all right.
There we go. Yep.
So Buckminster Fuller is a American architect from the 1900s, early 1900s, a system theorist. He was the inventor of the buckyball. For folks that are familiar with the geometric dome that you played with, that you could push in and out and make these big, massive squares. And he had a very interesting quote, I think, that basically suggests that humans learn by failure. And only if we assess what has happened when we try a process and have an error do we really learn. And so as we know humans fail, I want to spend the next few moments talking about how we learn to improve. Next slide. And so we have 2 different ways we gain knowledge when we think about improvement. We have subject matter knowledge and we have profound knowledge. Subject matter knowledge is the knowledge that you acquire through life, right? It's your ability to gain information by learning. That's how you learned how to ride a bike or learned how to bake a cake. It's also how you learned organic chemistry, or how you have assessed how to fix a car. Subject matter knowledge helps you. It's something you don't have when you're born, and only expands as you experience more and more through life. With regards to profound knowledge, this is the more abstract component of knowledge that you gain, and I want to talk about the 4 components on the next slide. And so these 4 components of profound knowledge are how we appreciate a system when it comes to the inner workings of it. And these 4 pillars, the theory of knowledge, understanding variation, and the psychology of knowledge, is something that helps us understand how to improve. And they're all interworking or intertwined with each other. And in the next slide, I'm going to talk about the four gentlemen that have had a huge, were pioneers in identifying these profound knowledge areas. So the first gentleman on the upper left, Dr. Deming, was an American engineer, and he is known as the father of quality. he first identified that in profound knowledge and how we improve, that each one of these components have interconnectedness in order to for us to learn and improve. And so he put together a leadership 14 points that assessed how we look at improvement and identify how those points are all interrelated. The second gentleman, Daniel Kahneman, was a psychologist by training. He took two of the components of profound knowledge, the theory of knowledge and psychology, and assessed how it affects us from a human perspective, specifically with regards to decision making. He was known and most known for his ability to think about the human factors engineering when we think about why events occur in a process and how the human interaction with technology or machinery or interaction between groups of folks identifies and can potentially cause harm as well as improve practice. The third gentleman on here is the bottom left, George Box. He is was a British statistician, and he looked within profound knowledge about the theory of knowledge and then understanding variability. As a numbers expert, he focused on when an event occurred, how do we go and assess and reproduce it? When we are looking at how many times we dispense a medication or are administering through a different pump library and all the clicks and whatnot, he would go through and kind of relate the variability in how folks are learning and then apply it to how we could further design a study to assess the functionality as well as the different requirements and to have appropriate results and whatnot. And the final gentleman on this slide is Dr. Joseph Jurgen. He was also an engineer, and what he did was put together what we now know as the Jurgen triad. And this is where he assessed in quality that there's three components. First, there's the planning phase of, you're assessing what you need to look at in a process. Maybe you've had an event and you need to walk through all the steps. You need to assess what is considered quality control. And then you go to the third component, which is quality improvement. He was one of the first adopters of the Pareto principle. And so Pareto principle, as you recall, is that 80% of the problem is caused by 20% of the causes. And he first socialized that idea that if you can start to assess a process in a systematic way and identify what is the root cause in an event or a trend of near misses, that if you can find 20% of the cause and effectively eliminate that cause from occurring, that you're going to decrease your problem by 80%. So all of these gentlemen focus on the different methodologies that we use today, knowing that all of these folks were not in a clinical role. So we have to think outside the box with how we compare it to healthcare. Next slide. And so I think that folks may know Dr. Mike Cohen. He's the president of ISMP. He had a great quote that sums up what we need to think about when we think about healthcare quality. When we think about perfection and zero errors and Six Sigma, which is defects per million, healthcare can't be measured to, we are going to have no deficits in our entire practice. I think ultimately an obtainable goal is that we don't have events that our ultimate goal should be that we don't reach patients, right? We have checks and balances within our healthcare system that's going to allow us to improve practices, and we're going to catch each other and not have the end result in patient harm. And so that is where we should be focusing our efforts. Next slide. And so the first tool that I wanted to go over for folks once an event has occurred, whether that be an actual event or a near miss, is the 5 whys. Next slide. And so the 5 whys basically is a way to ask a question once you identify a problem, and in a repetitive fashion, usually in a quick rapid fire fashion, to drill down into the root cause. It's something we've learned from a very early age, that you keep asking why until you get the answer you want. Well, by the time you get to that 5th why, is proven that you are more closely related to the actual root cause than if you stopped after 1 why, which maybe means that we should all be listening to our toddlers when they ask us why we can't have dessert after they've had plenty of sugar that day. Next slide. So when we think about an example of how you would use 5 whys, I've given the example of you're on your way home from work and your car stops. So why did your car stop? Question 1. You ran out of gas. Why did you run out of gas? Well, you didn't buy any gas. Now, if you stopped after question 2, you may be like, all right, so I just need to buy gas on my way to work. But is that really the reason you ran out of gas? So then you ask yourself 3 more whys. Why didn't you buy any gas? You didn't have any money. Why didn't you have any money? You lost it at a poker game. And then why'd you lose your money at a poker game? Well, you're not good at poker. So the real root cause would be that maybe you shouldn't gamble with the money you need for your to get to work. And so by the time you get to that 5th why, you really have a root cause that is something that you can think about action plans for. Next slide. And so I'm going to go through in the cases an example of a 5 why, but the next tool that I wanted to introduce was fishbone diagramming. Next slide. So fishbone diagrams, also known as a cause and effect diagram or an isoquality diagram, which comes from the lean methodologies, basically helps you categorize and identify different, through brainstorming, of why an event occurs. Yes, you still use the why example in a fishbone diagram, but you're trying to further delineate that one event does not necessarily result in a patient event happening. There's usually multiple layers of it, and categorizing the types of events happening or the pieces of a puzzle that are missing when an event occurs helps you further identify and improve the practice. Next slide. And so for this example, I have that at the top circle is, or at the far right, is the missed deadline, right? So that's the end result. That's the problem statement. And there's multiple reasons why deadlines are missed. You may have machinery, environment, materials as different categories, and you can see people, methods, and measurements. And so what this does is on a very granular level, kind of denotes every single piece that causes the overall root cause of a missed deadline, right? And so then what you do is you take this data in a group and try to categorize the different failures, if you will. And then as a group start to say, what are formulate action items with this, with regards to, how is this going to, what can be modified and prioritize your action items based on the fishbone, knowing that you have ultimately the different categories that cause the root cause. Next slide. So I want to go over, with the time we have remaining, 2 cases. So next slide. The first case that I want to review is a patient was on home infusion, was called into triage, and noticed that they had a 46-hour infusion regimen that had been hooked up a few hours prior, and it had stopped within 4 hours of the field nurse leaving. Next slide. And so the first thing you obviously do in any type of event review is try to assess all the different timelines And in the interest of our time, I did not include the timeline component, but that would obviously be in any sort of event review. The first thing you would do is gather all of the additional information, try to put together step by step what had occurred. Once we realized that the major problem statement was that the patient received a 46-hour infusion over 4 hours, then we started the 5 whys. And why did that happen? Well, the patient's pump was programmed incorrectly. All right, that's great. So then, like if you stopped at that why, then you would just feel like you needed to go and, reassess the pump. But why was the pump programmed incorrectly? Or how was the pump programmed incorrectly? The field nurse didn't assess that prior to the administration. And so why didn't that occur? Well, the nurse assumed that the pump was programmed incorrectly. And why did they also assumed that, or didn't realize that the patient's order was changed and a new pump wasn't sent. And so then you ask the final why of why was there not a new pump sent? And that comes back to one of the major root causes in many event reviews is communication component between the different disciplines within home infusion about what the standard practice is. And so we were able to identify that. Next slide. And so when we think about after we walked through a 5 whys, it's nice then to further delineate in a fishbone diagram that you see here, where obviously at the head of your diagram, you have the patient receiving the wrong medication, the wrong rate of medication, and you start to brainstorm all the different reasons why the patient received the wrong rate of medication, and then further categorize them. So from a dispensing perspective, we didn't have a new pump sent with the new settings. There wasn't a standard about whether we send a new pump or we do a rate change, right? And we had a covering nurse dispensing the product. And then there was also a component of double check piece that had been missed in this dispensing, just in the dispensing alone. What a fishbone diagram can do is further identify not only the category for action items, but also how interdisciplinary checks and balances can be in place. If we walk through the administration component, then we have the different components about the missed check, reviewing something as simple as the label of the medication matching what the pump infusion has. From a scheduling perspective, there was not documentation within the schedule for the field nurse to realize that there had been a rate change. So they were proactively assessing and being aware, putting in the forefront of that. And communication is a consistent category in many fishbone diagrams with vet reviews, where if it's not documented or it's not, you can't necessarily, especially from a remote perspective, assess what is occurring based on what either isn't in the electronic record or right in front of the staff at the home. And so then what you would do with this fishbone is start to prioritize what components or each of the smaller dash arrows into an action item to standardize and improve. Next slide. So I'll briefly walk through this so we have plenty of time for questions. So in this case, refills within a TPN patient were being assessed, and 10 mLs of multi-trace element was added to a TPN instead of the 1 ml standard. Next slide. And so when we looked at the 5 whys in this case, you obviously know that there was a situation with this is a compounding event, but what were the different relationships to why the compounding event happened? So the compounding record, the technician added the amount that was on the compounding record. And why did that occur? Well, the dispensing pharmacist entered the 10 mLs. And so once again, if you stopped after the 3rd why, you would inadvertently be then not realizing that the root cause after 2 more whys was that there had been a product change and that there was a miscommunication with that. And so when we looked, next slide, the Fishbone for this event, the incorrect amount of multitrace, there was lots of opportunities within the process of not only the process of preparing the TPNs, as well as the staging process, the people component, and also ensuring that technicians felt as empowered to question a record where there may have been something that didn't look familiar. And then also leveraging the equipment, whether that be the actually compounding machine or the electronic medical records. And then overall communication, specifically in this case, this was obviously a drug shortage related concern. And so how does that communication from the purchaser all the way on down to the person compounding, realizing that. And so then you can obviously build a action plan based on the opportunities within a process. Next slide. And so from a conclusions perspective, we have varying components of the human piece of healthcare, and our infallibility is a component, and making sure that when events occur, whether they be actual events or near misses, that your organization has a foundation for improvement, and then implementing the tools of assessing 5 whys and Fishbones can help you improve current practices and help you save lives. Next slide. And I love, this is Don Berwick. He is in the Institute of Healthcare Improvement, and he's a pediatrician by training. And I love this quote in the fact that you know that human error is going to occur. We need to step back and design ways to improve and to constantly learn with errors that happen or events that happen in your organization. And that's the end.
Great. Thank you so much. We do have a few questions. I just want to, again, this is such a great topic for us to have. We haven't done anything like this for quite a while in our conferences. And I know we'll be having you back. So, put us in your calendar for 2021. It's so devastating when there's a medication error to so many people. And so thank you for highlighting the importance of bringing things forward. So the first question I think I have for Matt is, this question is, their current EMR does not have barcoding capabilities. Do you have any recommendations on barcode scanning software that they might be able to integrate? What have you seen, Matt?
Yeah, that's a great question. And honestly, I don't have the list or know of all the barcode vendors, because I think my concern is I don't have faith in the home infusion software that most people are probably using to even use the barcode software right. So there may be some standalones barcode systems that I'm not quite aware of that, when it comes to using barcoding when compounding medications as an example. There is, though, specifically for barcoding, there are other softwares. One example is called Dose Edge. That uses photography and picture taking to help people check products, so that technician's going to make a Vanco, they'll lay out the drug, the syringe pulled back with the actual liquid in it, and the bag be put in, pictures taken. That's the kind of check, and then it goes on from there. So, barcoding could be one example, but there are other technologies for compounding that can be used. I'm just not sure it would be really readily integrated to your current EHR system.
Thanks, Matt. Hopefully we have some of our software companies on the line, as I put that in your to-do list there, because I know it's on everybody's list. Laura, who are some of the important people to pull into a performance of you when you're doing your 5 whys or a fishbone diagram?
Yeah, that's a great question. And there is 2 different ways to start off. You definitely want to have the frontline folks that were involved in the actual situation at the table. You also want, for lack of a better word, middle leadership, and also senior leadership at the end, to kind of first walk through the process. You want everyone to have be on the same playing field. So all the providers, whether pharmacists, nurses, intake folks, all on the same page when you're going through an event. But then also from a leverage perspective, once you start the action planning perspective, to get the buy-in from the leaders about what needs to improve. You want everyone to feel comfortable. A lot of times in any type of an event, you have varying amounts of understanding. So setting ground rules, very simple rules of ensuring that folks all feel comfortable is important, because you're going to have a wide gamut of folks in the room.
Great, thank you so much. So Matt, you mentioned that the proxy method isn't best practice, gave a great example, but what would you consider to be the best practice in compounding?
Well, the key thing is establishing a process to check ingredients before they go in the bag. I think that's really the key thing. Is right now we default to checking everything after it's done, kind of like retail pharmacy, where we check the bottle and the pills in the bottle and the label in the vial type of approach. But with injectable products, and again, mistakes happen where the tech may not pull the syringe back to the appropriate empty space on a syringe to somehow just flip the order of checking so it's more up front beforehand versus afterwards, but also make sure you're including remember, it's not just the right drug, but it's also the number of vials involved in that. So probably expanding the check process to go beyond just looking for particulate matter in a bag, but making sure it is the right drug and the right number of vials, the right amount of solution within the bag beforehand, but also making sure you got the right patients. Knowing that in home infusion, we like to batch things. Understandably, if I got a lot of Vancos to make, I'm going to make all the Vancos now, right? So how do I differentiate Laura and Jen and Ryan's Vanco doses when there are 3 different doses involved? So it's a matter of kind of just realizing that it's just not about the particulate matter in the drug. It's bigger than that, and just to make sure it incorporates more checks to account for what could go wrong before things leave the home infusion pharmacy.
Great, thank you so much. So that was our last question for today, although we do have one comment that said they wanted to just let you know that you did a great job, and they appreciated the education that you provided. So thank you again to Matt and Laura for sharing their vast experiences with us. If we did not get to a chance to answer your question today, a member of the NHIA team will get back to you. As a quick reminder, in order to get CE, please follow the link in the follow-up email to take the short quiz within 24 hours. It's worth repeating. Take the short quiz within 24 hours. Thank you to all our providers and suppliers who are working on the front lines to keep patients safe at home. We're looking forward to bringing you more education each week for our NHIA summer series. Have a great day.